All right. Welcome to all of our listeners to another episode of the SRS official podcast. And I'm John Vorhies from Stanford, and I'm lucky enough to be your host today. And I get to interview Michelle Welborn and Amy McIntosh. And these two ladies are very important and influential to my career. So I hope everyone will enjoy listening to what they have to say about some recent publications that they have. So Amy McIntosh is currently a surgeon at Texas Scottish Rite Hospital, where she did her fellowship, and she's the director of clinical safety. And she was the chair of the program committee last year for the annual meeting. And she's currently in the SRS lead program, which is one of the many ways that she's tied to Michelle Welborn, as they're both doing this SRS lead program together. And Michelle is the chief of spine at the Portland Shriners Hospital, and she did her fellowship in Utah. So welcome to both of you. Thanks for joining us.
Thanks for having me.
Awesome.
Thanks, John.
Yeah, it's cool. I get to interview all sorts of people with this program, and sometimes people I don't know, but it's fun to do you two, because I know you very well. Sometimes I have to sort of come up with like a list of questions to make sure that, the banter keeps going, because I don't know how talkative people are going to be, but I don't think it's going to be a problem today. Anybody who knows Michelle and Amy. So in honor of the 4th of July, I was just talking with my partner, Callie Towson. I said, with these two firecrackers, probably the best thing I can do is wear eye protection, keep my fingers out of play. And I think the podcast is going to run itself.
I think that's good advice for everybody on 4th of July.
Yeah.
When I run, you run, right?
Be safe out there.
Yeah, absolutely.
We have a lot of international listeners, SRS being an international society, but we're coming up on the 4th of July tomorrow. And the tradition, as put by one of my favorite Simpsons episode, is that we celebrate the birth of our country by blowing up a very small portion of it.
Yeah.
Anywho, okay, so we have a couple of great papers that you both put out today that I was hoping that we could discuss. And so I wanted to start us off by looking at Michelle's paper, which came out of the PSSG. And her paper in this current issue is called Coronal Decompensation Following Thoracic Vertebral Body Tethering and Idiopathic Scoliosis. And so this was a cool little paper that I wanted to discuss that talks about really a complication or a suboptimal outcome that I think hasn't received a whole lot of attention, specifically in anterior vertebral body tethering. It's something we talk about quite a bit, of course, in selective thoracic fusion and sort of choosing levels in general. But Michelle identified a cohort of VBT patients in the PSSG and looked at rates of coronal decompensation and tried to identify some risk factors for what we can watch out for. So, what any big summary points that you have for us on this paper before I get into some specific questions for you, Michelle?
Yeah, absolutely. So I think just one. Right from the beginning, the genesis of this paper was that, this is an exciting area, but we know that there's a lot of kids that do really well, and then there are a lot of kids that just do awfully. And I think that, what we really wanted to try to identify was why were some of these kids just not thriving, and how can we refine those indications? How can we try to make this better? And, it starts with identifying who's not doing well and why. And then I think at that point, you can start to kind of move forward. And so, as far as this paper was concerned, what we did is we looked at a lot of variables. We looked at size of the curve. We looked at how old they were. We looked at their rotation. But, the big thing was that all of these were a selective thoracic tether. So this is not a situation where you're tethering both curves or a hybrid construct. And really what we found was not surprising, actually, that if you were decompensated before surgery, you're much more likely to be decompensated after surgery. So whether that's because there is some difference in their innate balance, whether that's because they have, say, like a Linke 1AR curve, where that apex is lower, and we already knew that with a fusion, they were more likely to decompensate. And then Also, those that had 1C curves, interestingly, were also more likely to decompensate. And that probably runs a corollary to an earlier paper we did where we looked at 1A curves versus 1C curves and saw that the 1C curves were actually correcting substantially less in their thoracolumbar compensatory curve than the 1As. So by having a larger residual curvature, that probably contributes in part to that decompensation.
Cool. Yeah, it looked, I like the idea of sort of picking out, you know, a group of patients who did poorly and then trying to figure out, you know, what was it about them that put them at risk for this. And so it looks like, reading through your paper, you had 10 patients in total who had what you defined as coronal decompensation. And but you described sort of a few different patterns of it. And not all of them decompensated in the same direction that they were decompensated in the first place, right? Tell us about that.
Yeah, so you know, basically what we did is we looked at the decompensation at 3 different parts of their body. So we wanted to look at C7. We wanted to look at basically where the invertebrae was, and then kind of the apex of the curve. And then we looked we basically defined decompensation as more than about 2 centimeters. And so we looked to kind of see where they were before and where they were afterwards, and, you know, to see if there were changes in that. It was really interesting because those 1ARs in particular, and I think we've all seen this, they tend to kick that invertebrae out. So C7 is often still compensated, but at their invertebrae, they were often not. And there's a pretty good example of that in the paper, if you want to look at something that makes your tummy hurt a little bit. So yeah.
Maybe we can use the power of technology to throw that up on the screen there for people afterwards. Yeah, so 1ARs seem like one of the biggest like curve types and risk factors, which is interesting to me because I think I don't have as much tether experience as you, and I've been doing it for a little less time, but I've been really selectively applying, and one of my favorite people to offer it to is 1ARs because I feel like that patient population has the most to gain. Because, you know, of the long constructs we're sometimes doing with fusion. So I think they tend to lose a little more motion than a selective thoracic where I stop higher. But one of the interesting things that I saw in your paper was that you actually, you only included a selective thoracic tether. So that means you excluded patients who had constructs that went below L1. And so for a 1AR, based on some feedback from, you know, many mentors that I've gotten, I've always extended those below L1 because I'm scared of adding on.
Absolutely.
So how should we interpret your results? Do you think did you exclude some 1ARs you think that were instrumented below L1 that might have changed your understanding of that as a risk factor?
Absolutely. Yeah. So, you know, we didn't set out to look specifically at 1ARs. And I think that is kind of the next generation is to better understand that level selection, because you're absolutely right. The example in the paper totally stopped short of where I would have if it was a fusion. And so, and I also agree that I'm very, very selective in the tethers that I do. And when I do that, I tend to not err on the short side with those constructs. And so I think that while there's nothing in this paper that indicates a difference in level selection, it certainly indicates that stopping short and stopping at L1 is probably not a good idea for these kiddos. And that's probably contributing to why they're decompensating. You know, I think for me, one of the things that I wondered was if they have flexibility, are they going to be able to balance themselves, right? You know, I think that's always our hope is that their writing reflex is going to help them do that. But clearly what's driving them to be imbalanced is probably stronger. And so again, applying many of those principles that we learned from, you know, Bob Cho's paper and other papers that looked at linking 1ARs and the fusion principles is probably the right thing to do here.
Yeah, that was my question, Michelle. Then is the take home from this is that you should apply the same rules for choosing your distal level for a tether as you would for a fusion to prevent this decompensation?
So in this paper, we did not specifically see that. We looked at standard, neutral, and invertebrae, And the one thing we saw was that for those that went to the neutral vertebrae, they were less likely, right, to have that coronal decompensation. But overall, you know, I think that because the N was so small, I can't say that, you know. That said, I think so. So what the paper said and versus what I actually think, you know, we need to do this looking at 1ARs. And when we do it looking at 1ARs, and we're very close to having that,
It's your next paper, right?
it may already be mostly written. Yeah. So, but I think really the truth of the matter is that stopping short, I think we had hoped because of the increased flexibility early on, stopping short that maybe you'd be able to do that because people would compensate and they don't seem to be compensating. So don't stop short is, I think, what I can safely say here based on what's in the paper.
Yeah. And one of the other things that I wanted to talk about was sort of the follow-up period. And so you looked at 2-year outcomes, I think, primarily for this. And there's, you know, some great literature out of the harm study group looking at outcomes in selective thoracic fusion patients and noting that, you know, coronal balance continues to change up to 2 years. And those patients are presumably older. And one of the things I've noticed in my practice is that once a kid is sort of the same size for a year or two, I feel like they do a much better job of balancing themselves coronally than when they're still actively growing and they're, you know, maybe a little awkward in their sense of where their body should be. What do you think about that? And I mean, obviously everybody would want more follow-up in any paper they do, but do you think that colors how we should interpret your results?
Yeah. So I think one, we always need long-term follow-up, especially for tethers, because as that tether ruptures, because right, it's going to rupture. It's fabric. We want it to rupture, you know. So at some point that's going to rupture. Those curves may change or may not change in size depending upon how much remodeling has happened, but that's certainly going to impact that coronal balance, right? It's certainly going to impact the size of those curves. And whether that does it in a positive way because they're able to balance themselves better because of more flexibility, or if it does it in a negative way because of increased curve magnitude, you know, I think that's, again, hard to say. My sense from seeing some of the 1ARs is that they don't necessarily balance themselves better, but it seems as though the 1Cs that might happen where you might have more of, if again, you're starting off coronally balanced, that sometimes with that longer follow-up and that tether rupture that they do become a little bit better. So because they match each other better.
Mm-hmm. And one more question. Do you know if any of the patients that you had, specifically the 1Cs, got any bracing after a selective thoracic tether?
We don't know. And I can tell you that from the x-rays that I personally saw, having reviewed all of these, I did not see any in-brace x-rays. So I don't think many did, if any did. So yeah.
I'm going to just
And
propose it. So let's say you did a selective thoracic tether on a 1C, and then you could, and they coronally decompensated. I guess that's when you could consider putting in a nighttime brace to try to control that lumbar curve with substantial growth remaining. And it's not the most, I'd call it, difficult brace to wear.
No, I think that's a great idea. And I know that for my patients, I tend to work really significantly with physical therapy, working on things like mirror therapy, working on like stretching tight muscles, strengthening, you know, atrophic muscles, trying to like do a lot of like symmetric body exercise, you know. And so I'd certainly see some improvements in that, but I do think that it's a little bit of a different pattern with the 1Cs than the 1ARs.
Yeah, I agree. And I do think it's like something they can maybe learn to control their like the thoracolumbar curve more than they can learn to control that thoracic curve with the ribs attached. I think it's just a more difficult movement pattern to teach. Yeah.
Yeah, I've done that a handful of times, after, specifically in 1Cs, with tether patients and with selective thoracic fusion patients that still have some growth remaining if they just kind of didn't quite compensate as much as I'd hoped in their initial standing X-ray and they got significant growth remaining. I put them in a night brace and sent them to therapy. And then
Yeah.
I don't know if I'm just taking credit for natural history when they balance out after a while, but so far I've been pretty happy with how that's worked out.
I mean, you don't have a lot to lose, right? Like,
Yeah.
and
Yeah.
I personally think doing a nighttime passive bracing system with a daytime active movement intervention is a really nice combination of treatment options for patients as well.
Yeah. Yeah, I agree. And I love how you two are very proactive about this, because I think that's huge. And so the addressing those problems early on is so much better. And even if you can let the patients know beforehand, hey, this may be a part of your process. This may be something that we need to do. I think it's really, really huge because then it's not a surprise. And if it's a surprise, that's never very good.
Well, and I also
would
say, like, we're trying to never instrument your lumbar spine. We want to maintain your mobility, and this is maybe a way for us to prevent having any instrumentation into your lower lumbar spine, which is only going to benefit you going forward into the future. And I think if you sell it like that, everybody's on board,
Yeah, absolutely. I will put out the caveat that I very, very rarely tether the thoracic spine of a Elenchi 1C curve, just because of our earlier paper where we just didn't see the correction in the compensatory curves that we saw with the fusions. So unless there's somebody who really needs extension, I tend to err on the side of a selective thoracic fusion just because I think that we get more consistent results for those kiddos. But for other kids, then that's really reasonable. So yeah, just my caveat.
I think that's a really important point to make, Michelle.
Yeah. Lessons learned, right? I just wasn't, we have so many kids here that want to get back to sports and like crazy, crazy sports. I mean, I've got a kid that skis Super G and when he came in after crashing, and I was like, definitely freaking out, so I have lots of high velocity athletes. But I want them to all get back to sport, and I want to find that optimal outcome, both I think for the short term and the longer term, right? And that is a really important conversation to have, is what's going to be good for you now and how important is that to you now? Like if you're going to lose out on a college scholarship, then something that buys time for a few years may be really reasonable. Versus if you are going to miss out on one season of sports that you're not that into, but I love that we're all having these conversations with these patients.
That's key. That's key. Awesome. Well, thanks for sharing that with us. So I would summarize your take-home points as kind of, beware the 1AR and the 1C with tether and those patients with pre-existing coronal imbalance, because they might be landmines.
Absolutely.
And then stay tuned for your further work to tell us how to manage 1ARs.
How about let's caveat this as learn from my mistakes, or, let's not jump into the quagmire together.
Well, that's one of the wonderful things about writing a PSSG paper about tethers.
Yeah.
It's all of our complications.
It is. Yeah. Yeah. No, just.
Great. All right, Amy. So maybe we can move on to the paper that you have in this same issue. So you published a paper with your group there in Texas, looking at the effect of antibiotic-impregnated calcium sulfate beads and a medical optimization clinic attendance on surgical site infection in neuromusculars and syndromic patients. And so this is a sort of a QI model paper. And I think you presented this at SRS last year too, right? And you sort of track patients from 2016 on, when you at Scottish Rite started introducing selectively based on surgeon preference, it sounds like, the usage of calcium sulfate antibiotic-impregnated beads during closure for some high-risk patients, and then also sending patients to a multidisciplinary single event medical optimization clinic. And he grouped patients whether they, attended this clinic or got the beads or both or neither, and looked at their risk for infection and found that tacking on all the interventions seemed to be associated with a lower rate of infections. So that's a powerful outcome. So what led you to sort of write about this and take this approach?
Yeah, I think just like all of us, these patients, we see a lot of them, and we know that there are highest risk patients to have a complication after surgery. And so I think all of us want to try to do whatever we can to minimize that complication profile for our patients. And so as you know, at Scottish Rite, we're a pediatric, orthopedic hospital, kind of like a shrine, and we're not a full service children's hospital. And so I was trying to find ways to avoid patients requiring the need, to go to that like higher level full service children's hospital, because we don't have an ICU and we do not have the ability to have patients intubated at our hospital. And what I noticed is, I'm sure like maybe you guys notice at your institutions that, all the spine surgeons that do the same quote unquote surgery may or may not have been doing the same, medical optimization. Like maybe they thought we were like, yeah, I do that, but maybe it wasn't truly the same. So I thought the best way to tackle this was to try to truly standardize the process. And to do that, we needed for the medical optimization part to basically create a clinic. So what we did is we got sort of the whole team on board. And now if a patient has neuromuscular syndromic scoliosis and they have what I call more than one organ system involvement, meaning they just don't have an orthopedic problem, but they have an orthopedic problem plus a respiratory problem, a neurologic problem, they're bowel and bladder incontinent, they have more than one organ system, then they go to this clinic. And what happens is they come to a single appointment, and all the providers come to the patient. So they stay in a room, and then they see pulmonology, neurology, anesthesia, PT, OT, psych, nutrition, the dentist, social services, child psychology, and child life. So it takes about 4 or 5 hours, but instead of the patient and the family kind of having to go to a million different appointments, it's a little more patient-centric, and all of the providers come to the patient. They get to see the patient at a baseline, which I think is really great. And then on top of that, at the end of the clinic, we have a team huddle, and then every different subspecialty discipline talks about their organ system involvement, and then what treatment needs to be done to optimize their organ system. And then we have a nurse coordinator for the clinic, and there is a kind of like a roadmap in Epic, where then there's like check off boxes for, this patient needs a sleep study, this patient needs a swallow study, and then as they proceed through the medical optimization investigations, and then any interventions to improve those organ systems, it's all tracked in this document that is visible to everybody in Epic. And then once they've done that, then they're quote unquote, ready for surgery. But it's sort of a big team effort on the front end. And then I noticed we were all following like those, the POSNA guidelines, but we were still having a lot of variability with the number of infections we were having at the hospital. And I noticed also that we weren't always super consistent about which antibiotics were being, placed into the wounds. And so we worked to standardize that as well. And then the third thing was, I noticed that the adult arthroplasty and that Lawson Copley, doing a lot of musculoskeletal infection, was using this stimulon, which is just calcium phosphate. And it was a delivery system. So I always had a hard time figuring out, when I put Vanco powder or Gent powder or Tober powder into the bone graft, how long does it last? And, how much time is that helping our patients? And from the literature that existed, I felt that, at least with combining the antibiotic into the stimulon, it was a bit of a delivery system where hopefully the antibiotic would be in the local environment for a longer period of time and hopefully give us more prophylaxis than just days. So that's sort of a really long answer to your question. But then the hardest part is, as you know, these kids are really complicated. So trying to tease out which one of these, interventions makes the most difference was really difficult. But what I'll say is, I think it's all of it. Like, I think doing it all is, I don't know you're going to be able to say the one thing was the stimulon beads or the one thing was the medical optimization. I think it's that teamwork that is probably the way to try to, you're never, I think, going to prevent every infection, but at least you can get it as low as possible. And in the patients that got medical optimization and stimulon, they did have the lowest infection rate of the whole group, which was just about 2%. They were also the most difficult patients. They had, the highest GMFCS scores. They had the worst curves. They got fused to the pelvis more often. They were sort of the worst of the worst. And when comparing them to the other groups, they still had the lowest infection rate. So I think it's a positive finding. And I think, maybe you can't do the process we have here at your institution, but I think trying to do any preoperative process is great. And then I think standardizing how you're giving the intra-wound antibiotics is great. And then also, of course, everybody got like a non-dissolvable closure with nylons or staples and an impervious dressing with an incisional wound back to try to decrease bowel and bladder contamination afterwards. But trying to standardize what all the surgeons are doing, and then just tracking your data and being really honest and open about, when your infections are happening, and then just following it over time, I think is the key. But there's always ebb and flow. You're going to have great years where you're like, wow, our infection rate was like, again, 2%. And then you're going to have a little upslope. But I think if you trend it over time and you're seeing slow, gentle decline over time, then you're making some progress.
I mean, thankfully, these are common relative to, infections and AIS, but still, if you look at the numbers, they're rare outcomes. And so it's always the right papers about this, because you're talking, it's like, 10.29%, but that's one patient.
Right.
But that's,
when it's your patient, it's like devastating, right?
Oh,
and
yeah.
It's so devastating to the family as well. So, because we all know washing out a spine, T2 to the pelvis, is heartbreaking.
Yeah, we all want to avoid it as much as possible. But yeah, so congratulations. I mean, it's a big achievement to herd all those cats of different breeds into one medical optimization clinic. And, we've certainly tried it in different ways, and we settled on different sort of a different management strategy. And our institution is very different, obviously, for a lot of reasons, but we kind of do a preoperative care coordination visit and sort of do email consultations with all these different services. But I want to get Michelle's input on this too, because she's got this review article kind of discussing preoperative medical considerations in this patient population too. But so there's you have a bunch of specialties that were represented in your medical optimization clinic, but obviously not all of them, right? I mean, there's a lot of these patients have GI issues, and there's no GI, ENT, and so how did you pick who gets to come and who is consulted later, and what do you think are key components of this for someone who's building this program?
Yeah, for us, it's hard because again, we're an orthopedic hospital and only so many other subspecialties actually have privileges at our hospital, which is really goofy. So then if they have a cardiac issue, we don't have cardiologists. So then they would have to go see a cardiologist at another children's medical center and either have like EKGs or echoes. For the GI portion, we were lucky enough that we have developmental behavioral pediatricians, and they do a lot of that nutritional / GI workup. But then if a child does need a G tube or a GJ tube placement prior to surgery, then we would have to work with our other children's hospitals and general surgeons to get, G tubes or GJ conversions done before the spine surgery. So it's not completely all encompassing, but I do feel like trying to utilize the providers that we, do have available at our institution and have everybody seeing the patient sort of simultaneously and on the same page is probably the move that helped the most. And just open communication, right? Having like now when a patient, John, comes in, how Epic loves to like flash stuff up. So now it says NSP patient, neuromuscular syndromic patient, and then you can click on the box and it opens up their whole Excel spreadsheet for like how their medical optimization process is proceeding.
Is that the Epic procedure pass?
I wish it was. No,
Okay.
I tried.
I just got a briefing about that. But
yeah,
how do you do this?
I tried to have that in the Epic procedure pass. It was too complex.
Yeah.
So of course, our at Epic support people we created it ourselves in-house. I honestly think the Epic procedure pass might work best for really high volume homogeneous patients that are very similar. So like AIS, it would work really good for, just like maybe total joint. But these neuromuscular syndromic patients are so heterogeneous. It wasn't quite as helpful.
So that's what we went through a similar process, and because everybody has a different set of boxes to tick, it was really challenging to make that and build that into procedure pass. So we kind of have our running spreadsheet that's in Excel. Is that what you do? Is that?
Yeah, it's in Excel, but now you can just hover over it in this Epic's side window, and it opens up the Excel spreadsheet from like your Epic homepage.
That's great.
I know.
We want to wait. Like right now, it's just kind of to keep track of it and have other specialty providers see what the checklist is hard. But we can see our own internally shared spreadsheet. But sharing it in Epic with everybody who's taking care of the patient is a great
right
goal.
Just so it's transparent, to everyone, because I feel like that is the source of truth now, is like whatever people can actually see in Epic. Wouldn't you agree? Yeah.
What's your process, Michelle? How do you optimize this patient population?
So I love all the comments that Amy made, and similarly, we are, a Shriners hospital, so we don't have these specialists. In fact, we have even fewer specialists. So like your comment about this medical optimization clinic, I was like, that's amazing. And then I was also wondering, how in the world do you get your orthopedist to sit down long enough to do that? Because I'm not sure that we would sit down long enough.
Oh, they're not there. The orthopedic surgeons don't attend.
There we go.
That was the hardest part, Michelle, was to get everybody to realize that we don't need to be present, because we need all the other subspecialists to be on board and be present. And then we did hire an ICU intensivist as our like medical director of the floor. And obviously she is present because she will be helping manage these patients post-operatively as well. But yeah, that was the hardest sell.
Perfect. Because I was like, this is amazing. And I don't think I could fit it in my day. So yeah, so how do we do it? So one, I am so grateful for people like Amy and also Nick Fletcher, who have like helped to push this forward. I've used, he has this whole table with like how to like evaluate these kids, that he published a few years ago in terms of his like medical optimization. And he was gracious enough to send that to me. And so I then gave that to our team. And so we literally use these checklists that have already been developed by other places to really help identify those kids that have needs, get them connected as soon as possible. We also recently hired an incredible pediatrician who had done a lot of hospice work and been an internist, really loves these complex kiddos. And so she will liaise with them like early on. Like I like to connect them with her before they need surgery, because as soon as you see the writing on the wall, I want them in. I mean, honestly, even before that, I want to like anything we can do to fatten these kids up, anything that we can do to keep them healthy early on. I mean, it's not only just good for their health, obviously, and good for the family, but it just makes that whole process easier. So that's been huge. Our paper, again, the goal here was to try to find ways to help make things simpler, because so many of us are at these incredible academic institutions with wonderful resources at our feet, but there's the majority of spine surgery in this country don't necessarily happen at those hospitals, right? And I'd had a conversation with somebody, and who's doing this in a more community setting, and it was something where I realized that we often neglect those people when we're publishing some of our papers, when we're really looking at this stuff on like that infinitesimal level. Like, how can we break it down in a simple and algorithmic way to help these people? And so what we did was we enlisted these amazing people that we look to, and we're like, okay, break it down for the orthopedic surgeon in a simple way that tells them this kid should get evaluated and maybe this kid doesn't need to, right? And, that way somebody who's got 15 minutes can do this quickly, simply, and make it safer, right? And so that's really what we try to do here, because I think that so often we need that person who's got the incredible expertise to do the really complex stuff. But if you break complex stuff down into a series of simple steps, then a lot more people can do it.
Mhm.
So.
Yeah, not everybody has the resources to send everybody everywhere. So I like, I like having tools to make it more selective when it needs to be, if that's what your resources demand, so you can do the best with what you have.
What's interesting, John, is that we started it for the neuromuscular and syndromic spine patients, but now the medical optimization clinic has expanded. Now we're including some of the high risk Semmel's patients, so some of the lower extremity patients, and then also some of the complex hip patients. Because there's some kids with cerebral palsy, Down syndrome, CMT that are getting like complex hip reconstructions. We're having them also going through the medical optimization clinic as well. So it's interesting. It's so well liked now that it's expanding, out of just spine into other realms of pediatric orthopedics at my institution, which I think is a compliment. That means, people think it's helpful and benefiting the patients. So that's the highest form of flattery, I would say.
Yeah, we had a similar spillover when we started doing this preoperative care coordination visit checklist. We started it for spine, but then these hip operations, if you're doing a bilateral BR Dega, that's a operation of a similar magnitude with a lot of similar hemodynamic stresses, and so those patients definitely deserve a healthy dose of optimization.
Yeah, with similar medical comorbidities, they're
the same patients.
Yeah, they're all the same patients, right? It's just a different portion of the body that's getting the orthopedic surgery, but they still benefit from the I would say, like Michelle said, many eyes on the patient and trying to break something really complex down into these simple steps. I think it's helpful when you have a team, working on that together, of course.
Yeah.
Absolutely.
One thing I wanted to ask you is, so it sounds like one thing that's generated after this clinic is sort of a roadmap or what the boxes you need to check to get to surgery. What about after surgery? Does this group comment on sort of what things need to be done in the post-operative period? What changes to the protocol need to be made to optimize the management in the first few days?
Yeah, that's kind of the greatest thing. I think what we also saw come out of this is like patients weren't we couldn't prove it specifically when we looked at this, but length of stay is going down because now all of their home needs, we know them, ahead of time. So everybody's already got on board, all of the equipment needs they're gonna have, who they're going home with. If they've already got their CPAP or BiPAP before surgery because they've had their sleep study and they've seen the pulmonologist, so we're not waiting on that to go home. They've had their G-tube, or GJ conversion, and they're already on a feeding schedule, so all of that's kind of done pre-operatively. So then post-operatively, some of these kids are now going home, which blows my mind, in like 3 or 4 days post-operatively, whereas before they would stay 7, maybe 10 days, depending on, how they do. So that was another, really positive thing we're seeing, is because the plan is made ahead of time. Post-operatively, things are going, smoother than anticipated. And then I'll say the medical inpatient physician who manages their medical comorbidities, she can see them post-operatively as well, just to make sure, there's no other things that need to be like tweaked in the post-operative period. And we just do that for the 90-day global, right?
Mm-hmm.
After the 90-day global, if they need, ongoing care, then that can be taken care of by their pulmonologist or, GI person. But our medical floor coordinator, she kind of keeps them in her realm for 90-day global, which I think is good too.
Yeah.
Because I think some of the providers don't understand, what happens after this big surgery. And I think things really do settle after that 90-day period, and then they can go back to whoever their normal providers are.
Yeah,
I think that's,
go ahead.
oh, I would say that's a super salient point, because, they go home and they're hanging in there, and then, a lot of different things can happen once they go home. And so really making sure they're on that, positive trajectory, especially if they're going home sooner, because so often it's like, oh man, that big poop didn't happen and now they're not eating, and like, so just having that continued follow through is incredible, and having the bandwidth for that too is also incredible. So I think you just need a big team. And your comments earlier about just having the magnifying glass and looking at this really kind of echo some of that work that Mike Glotzbecker did, where he was like, things get better when you look at them, right?
Yeah,
and
you
when
turn the lights on.
that,
yeah,
right, exactly. It's like, oh, hey, wait a minute. There were rats eating through the rope in the rope factory, right? So I just I love how that really highlights it. I do have a question though. Do you think that this is more highlighting the process? Do you think it's the beads? Because I know Noelle
I know,
right, and
yeah,
find
that's the hardest part. I think that's the hardest question. And all I can say is, when we kind of got down to like the little group comparisons, I truly don't believe it's just the beads. But when you looked at the kids who got the beads and medically optimized, they were by far the sickest kids. Like they had, average Cobb was 88. They were all GMFC 4s and 5s, ASA class 3s, and instrumented to their pelvis 85% of their time. And that group, the infection rate was 2%.
Were they more recent? Were those kids more recent? No. Awesome.
Yeah, I
So
know.
awesome.
So it's interesting. So it isn't just one thing. I think that's all I can say. But
Yeah.
again, the reason why I like the beads is because I do feel like it's a delivery system. And I think that I don't know how long the antibiotics are going to stay in the local environment, but I think it's probably a little longer than when you just put the powder in.
Yeah.
And so I was in the group, of course, that used the beads. And it was like two of my other partners that used it as well. And I don't know that there's a right or wrong answer. But this is also like one of the first publications to use the Stimulon beads as an antibiotic delivery system in a pediatric patient population. So I think that's also important to say, hey, look, you can use this as an antibiotic delivery system in children, and it's safe.
Yeah. I
So
also
I'm
just
ready
love,
to, oh, go ahead.
I was going to say, I love where in the paper you talk about Brandon's paper looking at your trends in infection in like
Yeah.
the 1980s and the
It's
90s,
crazy,
the 2000s,
right?
and now. Right. And just how, again, the care has changed for these kids, how they're doing so much better. But, really that perioperative time frame is so pivotal. I mean, this is just, you guys have really, really been pushing this forward and doing such an awesome job. It's so awesome. So
What were you
yeah.
going to say, John?
Oh, well, I was just going to say, I'm following this work about Stimulon very closely, and I'm ready to incorporate it into my practice. I don't do it now, but I'm concerned about a couple things.
Okay.
I have been slowly and carefully trying to eliminate all drains from anything I do
As
that's
am
not
I.
already infected. And so
Yeah.
currently I'm draining very few, if any, spines. It's been since I put a drain in a primary spine, I can't remember the last time. And I am selectively applying wound vacs. And so most of the time I'll just do an occlusive dressing with no wound vac. But if it is oozy or, I think that I'm going to end up changing that dressing in the first few days, then I'll put in a wound vac. But I'm worried about wound drainage if I put Stimulon in there.
So great worries. So I had the same worries. So when I started using the beads in 2006, I was putting at least a superficial drain above the flat fascia in all patients. And then, like a multi-layered closure, nylons in the skin, and then an incisional wound vac. And then slowly over time, I am not putting drains in all of the patients anymore. The patients I put a drain in are the ones that have like, when they have that really bad pelvic tilt, and then when you level the pelvis, they kind of get that bad soft tissue pocket of
Generate a giant cavity in the lumbar spine.
Those are the only kids that I'm putting a sub-Q drain in now. And I think if you have a really good tight fascial closure and you don't have really big soft tissue pockets, that you do not have to put a drain in with Stimulon. But you have to have a really good fascial closure. I just put an incisional wound vac on while they're in the hospital until, this is going to be gross, they have that big poop where, because that always happens. And then once they kind of get that out of them, I take it off and then I just do an occlusive dressing like you. So I just do a regular dressing and then I put like big sheets of Tegaderm over the bottom half of the incision so that when they're changing diapers, they don't have to change the dressing. And then they go home with that on. And then I see them usually at 3 weeks to see if their nylons are ready to come out.
We have been using that incisional wound vac and love it. And one of the things I love is that it seems to really accelerate the healing. So when these kids are coming back in, it's like at least a week or two better than it would have been had they not had that. But we'll hook it up to a regular wound vac canister while they're in the hospital. And then we'll switch them. The version that we use, the battery pack lasts for 7 days. So we'll switch them when they get discharged. And they can either take it off at home or come back in and we'll take it off. a week after that. So they're typically getting it in the range for like, 10 to 15 days, depending upon, well, however long they had that. And it's been huge because a lot of those kids, they have more than one explosive poop,
Yeah.
I tend to use it in all the kids that are diapered, or like are particularly high risk. The one thing I hate is that it's it's pretty uncomfortable to take off. Because if it wasn't uncomfortable to take off, I would literally use it in everybody. Like my kid has a boo-boo and I would put it on it because like we're seeing huge differences in the rate of healing. And I think it's that suction, just really stimulating that healing.
So do you think that matters? Do you think it provides a benefit beyond being occlusive in a patient where there's no output? You think
Absolutely.
negative pressure?
I always say it's just like a fancy Band-Aid at that point, right? But it is a negative pressure Band-Aid, I guess.
Like on an open wound, like I understand that, but like if I've closed everything, do you think just sucking on the wound is helping?
I do. Yeah, actually. So it's really, since we've been doing this, we've noticed a huge difference in the rate of healing and the number of wound complications that we're having. And I don't know if it is simply that it's not wet, right? Because they're sweaty, because so many of these kids are sweaty, or if it's just, again, that suction on it, and that's stimulating blood flow to the area, but in like a positive way rather than a negative way. But absolutely, we do see that the rate of healing is faster in these kids. And it's a pretty big difference. All of our sutures are under the skin. So I don't use nylon.
You don't use nylons.
Staples.
Maybe that's the difference, John. Do you use nylons?
No, I do. So I do a subcuticular absorbable. And then I'm doing like one of the silver impregnated alginate dressings.
Oh, yeah. I use the silver impregnated dressing as well, but I'm still like I run a sub-Q and then I put nylons on top of that and then just back them till they poop and then do the silver dressing with, whatever to keep the poop out. Yeah. So I think sometimes we all do something a little different, right? So maybe the answer is you just have to do something and do it consistently and figure out a way to have a barrier so that urine and feces don't get on top of or in the incision.
Yeah. And I think keeping it dry matters
is key.
too.
Yeah.
Right. That's why I didn't always like some of those silver dressings, because the kids that sweat a lot, like sometimes they get a little mucky, and maybe I just have sweatier patients, but I really like that's keeping it dry, keeping it clean. All of those things matter a lot, but I've been very, very happy with this.
Yeah. And I can say, John, to your question, so I think, if you go to deciding you want to use the beads as a delivery system for antibiotic, I don't know that it means you have to use drains. I think you have to be smart about, your fascial closure and what your soft tissue defects look like. But beads doesn't mean you have to have a drain. Does that make you feel better?
It does. Yeah.
Good.
I'll report back.
Yeah, let me know. Watch the first one you do. Something will go south, right?
Hope not. Great. All right. Well, I think we're coming up on the end of our time here, but thank you both for an awesome conversation and for your great contributions to the journal. It's been a pleasure.
It was a pleasure. It's great to see you both. I hope you have a really nice holiday.
Yeah. Yes.
I'll be on call. I know. It's okay. And yeah. And so I'll hope to see you guys in Barcelona.
See you in Spain.
See you in Spain.
Looking forward to it.
Thanks for inviting me, John.
No solo stoves for us this time around.
Vorhies.
Oh, yeah. Those things are dangerous. Yeah.
So dangerous. Yeah. But no, have a wonderful day, everybody.
Yeah.
Thanks for having me.
Good luck with your case, Michelle.
Okay.
Bye.
Yeah, thanks.
You're like,
Bye.
bye.